Yeah,
Very good afternoon to one and all of you. And thanks a lot, Dr. Priya. She hasn't joined back yet
she'll
for
join.
including me in your course every year. And really, it's as if I've won a prize each time I see myself in a course. So thanks a lot. So going on. What's happening? Yeah.
Yeah, it's there.
So this is a very routine kind of a case, which I thought I'll start off with. See, you can see that's a large pupil, large and well dilated, and hydro is done, a good rotation is done, and then I've just got a superficial purchase of the new, very soft nucleus, and then I go and just trench it, and then I got two pieces. So there is one clear pace in the PC clarity, but still the nucleus is rotating freely. So I feel pretty sure no, but then there is vitreous there. And I've started off, I should have stopped earlier. I should immediately plug it with viscode. Now this very small quantity of nuclear epinucleus, soft epinucleus. So I go ahead, then I go ahead and do a vitrectomy, ensuring I don't hydrate the vitreous. And the ease with which now I'm able to remove the cortex is an indicator that the vitrectomy is quite complete. And with great confidence, I enlarge the incision. And absolutely foolishly, I go in with my three-piece IOL, thinking I have support on the two sides, and I've placed my IOL in the back. When I think with enough confidence, I go in to remove the viscoelastic in front and behind the IOL, wherein I easily see that the haptic is now slipping into that area of rent, and then it becomes jugglery to get the optic and the haptic up into the sulcus and then position it. So in the primary situation, as was very beautifully elucidated by Ajay and Partha, that you can do this only if you have converted a PCR into a PCC. Could you contemplate injecting an IOL in the bag, and especially a three-piece? And even if it's a three-piece, sometimes the way forcefully it tends to get injected, you have to be very, very cautious about the whole process. That even with a PCC, I wouldn't advise a three-piece. I would probably advise a single piece to be tucked in the way Partha told us elaborately how it has to be done. Now, this is a typical case of a polar cataract, and we have to always start the surgery thinking that the PC is actually open. So the first thing is you need to create a small rhexis, not too large, but not too small, of course, thinking that this might become the scaffold of placing the IOL and in the later date. Then the routine mechanical separation of the thing is attempted because there's going to be no hydro in this case. Visco dissection, maybe I would do after the nucleus bulk is removed and only the epinucleus is there. Most importantly, the whole manual should be so gentle, keep injecting visco so that the capsule bag never sort of gets compressed, the hydrostatic pressure does not increase. So it has to be a completely slow motion phacoemulsification and no extra manipulation in the eye. At this point of time, you could inject visco, do a visco dissection and have the entire epinucleus coming in. But sometimes you may be cautious, you may not do it, but it would get, sometimes you actually prolonging the step, you actually create more stress on the zonules. Then going through the side port, inject viscode because you already see a PCR, but the vitreous disturbance has not occurred. So gently tease from both sides, go in from this side port or that side port. At any point of time, you feel that the AC is challenging, go back and inject some more viscoelastic, push the vitreous back so that it does not come forward. It's quite safe and good because there was no vitreous disturbance there, and you've had your last piece out. So there's no need to do a vitrectomy in these kind of situation. Balloon up the space in front of the rhexis and the iris. And once you have done that comfortably, very slowly inject, ensure that the haptic is in the sulcus space, rotate it and position it, and then remove the viscoelastic, and then just tap on the optic of the IOL and do an optic capture. And then you have realized as if it was a single piece in the bag, and you would get the same kind of a visual outcome in these kind of eyes where it has been a well done surgery. Now, this is a case where the surgery is, the nucleus is out, but you've created that small flap in the posterior capsule. One, I could have gone and done a PCC, or keep the phaco probe inside the eye, go in through the side port and inject viscoelastic so that again, you are pushing the vitreous back so that it is kept tamponaded. And then maybe here in this particular case, I'm injecting a single piece IOL exactly the way it has to be done into the AC, gently nudge the haptic, into the capsule is going to act as a scaffold. So as there was not much of an obvious vitreous disturbance, here the haptic has been placed in the sulcus. But if you want, you could leave the haptic on the iris itself. And then once the IOL is placed, now with this protection, which is well covered the pupillary area, you could do phacoemulsification and remove the remaining nuclear fragment. By now, it's obvious there's enough vitreous disturbance. So you go behind the IOL, do a thorough vitrectomy, and in the process, some of the loose cortex and all comes forward. You check whether there's any vitreous in front. As you can see, a strand was there. Inject Triquart at this point of time. Ensure there is no aberrant vitreous strands anywhere. And then you have done the surgery. Now, this is a case where the patient came from elsewhere with a decentered single piece IOL and an obvious PCR, which is there. So first and foremost, before you start any manipulation, you should do a gentle vitrectomy. There was not too much of vitreous presenting, just a blob of vitreous was seen, and do a good vitrectomy, because now you're going to do something different. You're going to manipulate the IOL, which is actually sitting in the vitreous partially and partially in the capsular bag. And after having done a thorough vitrectomy, you're sure that you have got the single piece IOL up on in front of the rhexis. And now you would inject viscoelastic and enlarge the opening. You need not cut all the way through and through. You could do it whichever way you want. Sometimes you could just go halfway up and then that hold that point, and that acts as a fulcrum. And then you remove the entire optic of the optic and the haptic of the IOL. And then you inject viscoelastic, again balloon up the space in front of the rhexis, and then place your lens. Do a little vitrectomy if you feel you have disturbed the vitreous. And then if the rhexis is round, do an optic capture. This is the last video which I'm going to show a similar case. It's a decentered IOL. So first and foremost, you place your iris hooks, because it's not very clear. Is it just a dialyzed bag because of which the IOL is decentered? Actually, if I was sure it's a multifocal IOL, if I was sure that there's a subluxation, then I would have placed a CTR, but it appeared as if there was probably a PCR there, which was missed out and the IOL has been placed. So I get the entire IOL outside. And as I had alluded to, keep my side put away, and then with the other vitrectomy, do the cutting, inject Triquart. See, there's a lot of strands in the anterior chamber and in the posterior chamber, and then inject a 3-piece multifocal IOL was injected. We do keep a battery of these lenses in these kind of situations, but you need to undercorrect by 0.5 and then position the IOL in the sulcus and then do an optic capture, and of course place a suture at the main wound, and thus you have bailed yourself. Oh, this is the last video which I have. Here there is the patient came back the next day with an epinucleus fragment behind the IOL. At this point of time, it's mandatory to place a pars plana entry and place a trocar, because you're not very clear how good the PC is, because it was a PC which is a PC rent which has occurred, and the surgeon has not known and placed the IOL. So you would not want the PCR to enlarge. So you would like to do a vitrectomy from the pars plana where there is less vitreous which is going to come forward, and you are cutting vitreous at its home. So there is going to be less traction on the vitreous base. And once you have ensured that the epinucleus is out and the visual axis is clear and the vitrectomy is thoroughly done, you could even inject Triquart at this point of time to further check whether you have done a complete job of doing a vitrectomy, which is what was done. And then you complete the case. So essentially, manipulating an IOL with an evidence of PCR, one is convert the PCR to a PCC if you could help it. Try to place a single piece IOL in the bag only. Even if you feel there's enough on the posterior capsule, gently nudge the haptic into the bag. Otherwise, place a 3-piece IOL in the sulcus and do an optic capture. And rarely, if you could place a 3-piece IOL in the sulcus, if there's not enough space, you feel the PCR is large and the rhexis allows it, then you could even do a reverse optic capture and get the optic out of the bag and just the haptic in the bag, and thus bail yourself in all these challenging moments. Thank you.